I'm Ken Anderson from Dana-Farber Cancer Institute and delighted to talk to you about myeloma, the cure around the corner. Here are my disclosures. As you know, there have been remarkable advances in myeloma with the advent of the proteasome inhibitors, the immunomodulatory agents, an HDAC inhibitor, monoclonal antibodies. And even during the pandemic, we've had additional approvals with selinexor, the immunotoxin belantamab mafodotin, the prodrug melflufen, and even CAR T cells. And all of these agents showed their value first in advanced disease and now are being moved earlier. The bottom of this slide, there are 30 different FDA approvals, 13 agents, and this has made a remarkable difference in our treatment options and outcome for all patients around the world. Now, if you're a transplant candidate with newly diagnosed disease, this is the menu from which we can choose drugs. And we commonly choose 3 drugs, lenalidomide, bortezomib, dexamethasone, for example, called RVD. But in the middle of this slide, now it is becoming much more common to add daratumumab to RVD, a quadruplet therapy as a preparation for a stem cell transplant. Now, why do we use RVD or 3 drugs? Shown on this slide is a trial that we did together with our French colleagues of RVD, as I'm outlining here, alone, or RVD followed by a stem cell transplant. And in this trial, the DFCI-IFM trial, there was in fact an advantage for using the RVD followed by the transplant that was statistically significant. What's so remarkable about this is we can get MRD negativity, fewer than 1 myeloma cell in 1 million normal bone marrow cells, whether we'd use drugs alone or drugs plus a transplant. And down here in the lower right-hand corner, MRD negativity, fewer than 1 in 1 million myeloma cells in the bone marrow, does confer advantage in terms of time without active myeloma, known as progression-free survival, and overall survival. Now, this is a slide that I borrowed from the Emory Cancer Center, and it's quite remarkable. This shows you how well patients can do who receive RVD and a stem cell transplant followed by lenalidomide maintenance if they have standard risk myeloma, or lenalidomide and bortezomib if they have high risk myeloma. On the left-hand side, this is the progression-free survival time without active myeloma. You can see it's 77 months if you have standard risk myeloma, and the overall survival of standard risk myeloma patients is not reached yet. And you can see this goes out to 140 months. So it's quite remarkable. Now, why is daratumumab being added to RVD? Well, there was a randomized trial of either RVD on the right or daratumumab RVD as preparation. All these patients got a stem cell transplant, and then RVD or dara-RVD was given as consolidation, and then maintenance was given with Revlimid or Revlimid and daratumumab in the daratumumab RVD arm. And I show you this slide because when the 4 drugs were used, dara-RVD, the rate of MRD negativity was higher. It was almost 70% by the time patients got to maintenance versus only 30% if you used RVD alone. So that's why it's a depth of response. More significant MRD negativity can be achieved with the addition of daratumumab. Now, in addition, that works even in high-risk myeloma. What about if you're not a transplant candidate because you're older or because your heart, lung, liver, and kidney function doesn't make transplant safe? Well, daratumumab is now being added into the early management of non-transplant eligible newly diagnosed patients as well. So, for example, daratumumab Revdex, the so-called MAIA trial, and the addition of lenalidomide bortezomib dex, or RVD light, is now being explored together with daratumumab as well. So let me just show you in one slide here. This is actually the different regimens that can be utilized for non-transplant newly diagnosed patients. This is RD versus VRD, and you can see VRD was superior. In terms of the MAIA trial that I just mentioned using daratumumab, it was daratumumab Revlimid dex versus Revlimid dex here. And this dark blue row here shows you that in fact the progression-free survival or time without active myeloma has not even been reached. With maturation now, both the progression-free survival and the overall survival is longer using daratumumab lenalidomide dex than lenalidomide dex alone. Now, I mentioned this already, but this slide just summarizes a number of trials in which daratumumab has been used initially as part of treatment in myeloma patients with high-risk disease. And the only thing I'll show you, I'm pointing out here on the right, is that daratumumab works even in high-risk myeloma. It can abrogate the early return or relapse of myeloma that is characteristic of high-risk disease. Now let's move quickly to what happens when myeloma comes back or relapses. You and I think of many factors. We think of frailty. Is the patient fit or frail? What other diseases, diabetes, renal disease, etc.? What's the cytogenetic or high risk category for the patient's disease? And most importantly, what's the prior history? What's the goal of therapy? Maybe an oral therapy was particularly relevant during the pandemic, or a preference for those of you who live far from a treatment center. Here is the menu for treating relapsed multiple myeloma. And we have regimens that are worked and can be utilized if the myeloma is refractory to bortezomib or refractory to lenalidomide. But as I've already mentioned up at the top of this slide, many times early myeloma treatment involves both lenalidomide and bortezomib, and we have these regimens that can be utilized in that setting. What happened even during the pandemic is at the bottom of this slide, we had a number of FDA approvals: selinexor, belantamab mafodotin, ide-cel. All of these were approved even during the pandemic, and I'll show you some of the data. So if your myeloma is refractory to lenalidomide, there were a number of trials that compared bortezomib dexamethasone with or without pomalidomide or daratumumab or carfilzomib, selinexor, or venetoclax. And in each case, the 3-drug regimen was superior in terms of the likelihood of myeloma returning. We call it the progression-free survival was in favor of using all the 3 drugs. And this is in the context of lenalidomide refractory myeloma. This slide shows you the opposite. If your myeloma is refractory to bortezomib, a number of clinical trials have been done comparing lenalidomide dexamethasone with or without the oral proteasome inhibitor ixazomib, with or without the antibody elotuzumab, or with the proteasome inhibitor carfilzomib, or with the antibody daratumumab. And in the red box, the 3-drug regimens in each case were superior in terms of longer progression-free survival. These particular slides summarizes other regimens that are useful even in myeloma refractory to both lenalidomide and bortezomib. So we have pomalidomide carfilzomib backbone trials. So on the left-hand side here, is pomalidomide dexamethasone, and I'll just point out with or without elotuzumab, with or without that's a SLAM F7 antibody, with or without the isatuximab CD38 antibody, and with or without daratumumab, the CD38 antibody. And the dark blue bars show you that adding a third drug to pomalidomide is statistically significantly better. On the right-hand side is adding drugs to Kyprolis or carfilzomib dexamethasone. Here we have daratumumab, carfilzomib dexamethasone, and most recently approved, we have isatuximab. Both of these are CD38 antibodies added to carfilzomib. In each case, the 3-drug regimen was superior. Now, during the pandemic, the nuclear transport inhibitor selinexor was tested in patients with only 1 to 3 prior therapies. It was bortezomib dex with or without selinexor in these patients. And on the left-hand side, the time without myeloma was longer, and this benefit was shared in all subgroups of patients. So this led to the first FDA approval during the pandemic. We also know that in the 11-14 subset of myeloma, that's about 10 or 15% of you, that the addition of the oral venetoclax medicine, which targets a gene and protein called BCL2, can make a big difference. Here is the time without myeloma on the left here in the green. If you receive venetoclax together with bortezomib dex versus bortezomib dex in the blue, it's a big advantage, but that's not true if you don't have that subset of myeloma that overexpresses BCL2, including the 11-14 translocation myeloma. This regimen is not yet FDA approved. Another agent that was FDA approved during the pandemic is called melflufen. Think of this as a prodrug. In other words, you take it by vein, it goes into your bloodstream and it goes to the myeloma cell, and it becomes melphalan because the myeloma cell has an enzyme called aminopeptidase that can break down melflufen into melphalan. So the idea was you would get higher concentrations of melphalan in the myeloma cell and maybe have fewer side effects. This agent was approved, about a 30% response rate. People lived about a year, even in myeloma that was refractory to proteasome inhibitors and IMiDs and CD38 antibody. Another agent that was approved just about a year ago now by the FDA during the pandemic was belantamab mafodotin. This is targeting BCMA on myeloma cells. So it's an antibody that binds to BCMA and it brings a toxin to the myeloma cell, thereby using immunologic mechanism and the toxin to kill the myeloma cell. It was FDA approved at the dose here on the left of 2.5 milligram per kilogram because about a third of patients responded, lasting about a year. Now, this agent does have keratopathy or visual changes, and so there are many protocols now testing combination agents and schedules to see if we can optimize the efficacy while minimizing the side effects, in particular, the visual changes. Now, perhaps the most noteworthy approval that occurred during the pandemic was that of the CAR T cells. I think you all know what this means. CAR T cells are formed or produced by removing from your bloodstream the immune T cells outside of your body. Those T cells are infected and educated, if you will, to react against BCMA positive myeloma. They're grown up into large numbers, and as I like to say, they're transfused back to you as your own immune army. The approved agent is in this left-hand column. It's called ide-cel. Overall, the response rate was 73%, and overall, it only lasted 8.6 months. But at the dose that was really optimal, at 450 million cells that I'm pointing out here, the overall response rate was 81%, and the duration of progression-free survival was extended up to 12.2 months. You will see remarkable progress. The cilta-cel product has already been submitted for FDA approval, and it has a progression-free survival of 22.8 months. So these agents are active in far refractive disease, and with further development are going to result in long-term progression-free survival. Now, this is a concept I wanted to quickly mention to you called the Bat car. Many of you will remember Batman and Robin. But here on the left-hand side is a typical regular CAR T cell. The T cells at the top, the tumor cells at the bottom, and there's a switch that's put into the myeloma cell, and it targets BCMA on the surface of there's a switch that's put into the T cell, the immune cell, that programs it to activate an immune response, and it binds selectively to BCMA protein on the myeloma cell. The concept of an indirect CAR T or a Bat CAR is you have the same switch in the immune T cell, but it reacts with a protein called X here. And you can beforehand give an antibody to patients like daratumumab or isatuximab reacting with CD38 or SLAMF7 reacting antibody elotuzumab, but label the myeloma cell with an antibody that's bound to molecule X and give CAR T cells that only get activated when they bind to protein X. In other words, you can label the myeloma cells first with daratumumab, isatuximab, or elotuzumab with that antibody bound to an X label, and then give CAR T cells that only get activated where you want them to get activated, in people at the site of myeloma. The last thing I'm going to mention are bispecific T cell engagers. These are medicines that you get by vein or subcutaneously. They react most commonly with BCMA on myeloma, but there are some other targets too, GPRC5D or FCRH5. They react to the myeloma by virtue of that binding, and then they react with the immune T cells by binding to CD3. So they're called bispecific. But what's remarkable on this slide, half a dozen of these are in clinical trials or more. Even in phase 1 clinical trials, the response rates are as high as 70 to 80%, and the tolerability is quite acceptable. Again, these are early trials. We don't know much about long-term follow-up, but very exciting progress in immunologic treatment of myeloma is palpable. I do think that these agents that I've mentioned, CAR T cells and bispecific T cell engagers, so-called BiTEs, are not going to be used by themselves. They'll be used in combinations. Here's an example. This is one BiTE from the Amgen 701. So in an animal model, if you combine the BiTE together in this example with lenalidomide, you can markedly enhance the growth of human myeloma in a mouse. And on the right here is the human myeloma growing in the mouse, and then you add in the BiTE, and you can see in the green line, the BiTE plus lenalidomide has the most impact of all. And finally, we're learning a lot about some of our old friends. So we, have been using bortezomib to treat myeloma for 20 years. And it works by inhibiting the breakdown of protein by blocking the proteasome. But recently we found a very exciting finding. Bortezomib here over on the left, given to myeloma cells, results in killing the myeloma cells. And on these dying myeloma cells, they express something called CALR or calreticulum on their surface. That allows these dying myeloma cells to be taken up by dendritic cells, or cells that present these dying myeloma cells to your immune system. Down here in the lower right corner, this results in immune response, in the induction or triggering of an immune response in patients against their own myeloma. And that's shown here. This immune response kills the myeloma cell. In other words, this immunogenic cell death is newly recognized effect of bortezomib, and we've shown that those people that get this immunogenic response do much better. So this suggests, in the excitement around immune therapy, that perhaps bortezomib, which we would have never expected, would be a good partner treatment. So what I've tried to say is we have a very exciting time in myeloma. I started out by saying that we're going to use bortezomib and lenalidomide, dexamethasone, and CD38 antibodies up front. 4 different agents pretty soon will be routine because of the high rates of MRD negativity. I think you're going to see then, after one achieves high rates of MRD negativity, where we use transplant today, pretty soon we will be doing clinical trials of these CAR T cells and BiTEs that I mentioned at the end, these very promising immune therapies. I mentioned that I think combinations are really important. The bispecific T cell engagers with immunomodulatory drugs such as lenalidomide. And I mentioned the BAT CARs, or BAT CAR T cells. So exciting, I think, because we could use commercially available antibodies and have construction of a BAT CAR inside the patient. Give the antibody, give the CAR T cells, should be much more effective and tolerated. And then at the end, I said, you know, even some of our own drugs, proteasome inhibitor bortezomib, has new effects that are recognized, such as inducing an immune response. The most important message I want to leave you with today is we are positioned now to have long-term disease-free survival and even potential cure in myeloma. And the reason is we can use combination targeted therapy, as I showed you, to get high MRD negative rates. And we can now, with our immune agents, generate an immune response in patients against their own myeloma. Once these 2 things are achieved, then patients can be free of disease and off all therapy, and that's a potential cure. Thanks so much, and we'll have a question and answer period now.